Okay, I believe in starting on time and being grateful for the folks who can join us on time. So thanks everyone for joining us this afternoon or morning if you're on the West Coast. I'm Floreo's Director of Customer Success, Heather Manning, and I'm going to introduce our esteemed panelists in a second here. But before I do that, I just want to let everyone know we are recording the session. And I want to encourage you to put your questions in the Q&A throughout the call today. We will be hosting the Q&A session at the end of the presentation here. So joining me today, I have with me two wonderful panelists. Denise Garcia is Floreo's General Counsel, sorry, blanked there for a second, Denise, and also Head of Market Access. And Jenna Minton is the CEO of Proactive Strategies. And they're going to tell you a little bit about the CPT III code billing for virtual reality assisted therapy. So I'm going to hand things over to Denise and take it from there.
Thank you, Heather. Hi, everyone. Thank you for joining us. I wanted to let you know a little bit about Jenna and a little bit about my background at Floreo. So I had the good luck of reading a Washington Post story about Floreo 5 years ago. And I reached out to VJ and said, hey, I would love to have coffee. I'm the mom of 4, including identical twins who are 25 on the spectrum. And so as soon as I read what they were doing, I was like, wow, this is so cool. So I've been with the company for 5 years, and it's really exciting because I think we're really reaching a new level now. And so I want to give you a little background on how we got connected to Jenna. So when we started thinking about the long term of the product and how we're going to get it to people and how they're going to be able to pay for it, we realized our best option was to go through the medical route instead of just making it something that someone can buy over the counter. We wanted to make the product, and we have from the very beginning, made it very evidence-based, and it's based on clinical research that's been done from the beginning. And so because of that, we have the opportunity to actually apply to become a medical device. And that is the route that we are taking. So in preparation for this, we went ahead last year and we put in an application to get a CPT III code. And we were luckily successful. It is the first virtual reality mediated therapy code that is out there. It's pretty exciting. We designed it to be very broad, quite purposely, because we want anyone in any kind of therapy or a social worker to be able to use Floreo as a product along with their therapy. And so that is a code that has gone into effect in January. It's 0770T. And Jenna is going to describe more about it. Now, Jenna is an attorney by background, and she's been working on reimbursement issues for a very long time. And correct me if I'm wrong, but you helped ABA get their CPT codes through when they started as CPT III codes originally. They were originally tracking codes. And my understanding is they were paid by payers for about 4 years as a CPT III tracking code before they were able to transition to a CPT I code. And Jenna's going to explain what that means. The one thing I would say is the CPT I code is what we want to get to. And in order to get that code, we have to be a medical device. And so we are in the process right now of doing some pivotal research to support our application to FDA. And we anticipate that we'll be able to apply next year. And that is the goal of all this process, just to start educating everyone about what the CPT code is, how it can be used, talking to your payers about it, so that when we do get that medical device status, we can go ahead and get reimbursements and submit for a CPT I code. So that is our strategy. I'm going to turn it over to Jenna.
All right. Well, thank you both so much. I'm really excited to be here with you today. I'm just going to make sure we get our screen share up and running. Okay. Can you see that all right? All right, perfect. So thank you again for inviting me to participate. We're going to talk a little bit about the history and implementation of the Category 3 CPT code 0770T today. There we go. So we already covered our introductions. And just a little bit about how we got here. Denise did a nice job of covering the pathway that Floreo took before Proactive Strategies was starting to participate and support the effort. But in 2022, as was mentioned, Floreo engaged a consultant to submit their application to the CPT editorial panel. And the panel approved this, which is a wonderful start in and of itself. The panel has multiple options when they review applications, and approval is not always the route that they take. So to do that on your first try is a great accomplishment and very exciting. This year, as was mentioned, on the first of the year, the code did take effect and is in the published 2023 CPT code book that's put out by the American Medical Association. But in March of this year, Floreo decided to partner with us, me and my team, to support implementation of the code with payers and to educate providers on the use of the code in conjunction with all of those clinical services that Denise just mentioned. So today we're just going to talk a little bit about a brief history on how we got here, using the code, essential resources that if you are already using the code and or Floreo or considering utilizing it in your practice, that you want to make sure that you have to set yourself up for success. Important terms and concepts, and then give you some payer implementation updates and talk a little bit about what we've done and where we're headed on the advocacy side. So to start, and you may feel like, you know, I'm interested in the technology and I don't really get all that involved in coding and I don't know very much about coding, or maybe you aren't reporting CPT codes yet to health plans. I think it's really important to have at a minimum, basic understanding of what these codes are, how they're developed. So we're going to spend a little bit of time talking about that today, just because as you dip your toe into these waters, being as informed as possible is really important to have positive working relationships with your health plans and make sure that you're signing contracts that long-term your practice is going to be happy and successful with. So CPT stands for Current Procedural Terminology. They are descriptors and identifying codes for reporting medical services and procedures for private and public health insurance. And as was mentioned, codes are issued, copyrighted, and maintained by the American Medical Association. So the AMA owns all CPT codes, and it is copyrighted information. So you need to keep that in mind when you're copying and pasting and sending things and emails and all of that. In terms of, I'm just going to move our heads here so I can see a little better, the CPT code process. You can submit an application to establish new, which was the case here for this T code, or modify existing codes to the panel. And this is often done by practitioner groups or professional societies that you can join and be a member of. Individuals, though, like myself as an individual out in the community, are also able to submit applications should you have interest in doing so. The editorial panel meets 3 times a year to review these submissions, and medical and other professional societies or external interested parties, so again, members of the community, can comment on those applications. And as I mentioned, the panel has lots of options here in how they respond to submissions. Those possible decisions are to approve, disapprove, or delay time certain or not time certain. And you get that feedback often. You sort of know the way the panel is leaning before you go to the in-person panel meeting, but sometimes at the actual panel meeting, those decisions start to come together or come to light, and then ultimately there is a vote and the formal decision is published in an action memo a few weeks after the meeting. So what is the difference between, it was mentioned that there are Category 3 and Category 1 CPT codes. What's the difference? We currently have a Category 3 code, and Category 3 codes are temporary. They are issued for things that are new and up and coming, and they're intended to allow a period for collecting data on what the panel refers to as emerging technology, emerging services, or emerging procedures. There must be some evidence of clinical efficacy and utilization, but as we'll see when we get to Category 1 requirements, those expectations get bumped up quite a bit when you're applying for a Category 1 code. Payers do not have to adopt Category 3 codes, and those who do often impose their own interpretations. So that's really the crux behind why Proactive Strategies and Floreo are partnering together, is to make sure that we are getting as many payers as possible to implement the code, and also hoping that they will do it in a manner that's consistent with the vision with submitting the code and getting it approved and the ultimate use of the code. These, as they're temporary, have a 5-year window, and at that point they are either sunset, which means they go away, they get taken out of the CPT code book, or they get upgraded to Category 1 status. They also can be extended for another 5-year period, but as has been mentioned, our goal is obviously to get up to that Category 1 level as soon as possible. So in contrast, Category 1 CPT codes require that a procedure or service, or in this case, a technology, must be performed by many physicians or qualified healthcare professionals. It must be performed with a frequency consistent with intended clinical use. So what in the world does that mean? A shorter way to say that the panel often uses is widespread use. So if it's a service such as Floreo, where when you get to the maximum use that we might be able to envision or imagine, that's a pretty high utilization, right? Because it can be used with so many different types of clinical therapies and approaches. So, and if you think about the frequency with which some therapies are delivered, perhaps ABA is delivered 5-7 days a week, and you think about ultimate across the United States volume for 0770T, thinking with Floreo as our example of the technology, that widespread use is a pretty high bar. It needs to be consistent with current medical practice, and we need to have clinical efficacy documented in research that meets the rigorous AMA requirements. These codes are appealing because rather than being temporary, they're permanent. There's no sunset period or re-review period required. And payers that process claims electronically must adopt Category 1 codes per HIPAA standards. So they can supplement with HCPCS codes and other codes, or they can have some payer policies that maybe modify the intended use of the code, but the code itself does have to be in their code set if it's a Category 1 status. And so that's, again, one of the reasons that reaching that level is so appealing. So what does it mean to have a Category 1 code? Eventually, there should be more uniform and consistent adherence to the code descriptors as approved by the panel. Again, as I just mentioned, payers do always have leeway in setting their own policies and having their own manuals and contract language. So you really have to be on top of having the most up-to-date documentation from them. It should mean fewer denials of coverage for services on the grounds that they are experimental, unproven, not medically necessary sometimes. And if you're already using 0770T, you may be seeing some denials with those types of terms. If you are, please let us know, and I'll talk a little bit about how to do that in a minute. But those are important things for us to know so that we can start educating payers on why that's not the case. Opportunities to extend coverage of services to client populations. And I apologize, this is clearly pulled from one of my ABA is the world I mostly live in. So we've got ABA there, but just supplant that in your minds with all of the therapies that apply to this particular code. So to extend coverage to all client populations rather than 1, 2, or 3 specific ones, but advocacy might be required. And then just noting again that our goal will be to elevate the 0770T to a Category 1 add-on code. I'm going to talk a little bit about what add-on means as well. So how do we use this specific Category 1 code as it stands today? Essential resources is where I would absolutely encourage you to start. So again, the AMA owns all of the CPT codes and HCPCS codes, and to have them in one easy to use place. Every year in August, they publish the coming year's CPT book. They publish this in an online PDF version. They also publish it in print, which is what the image on the slide shows. So for instance, this August, the 2024 CPT code book will come out. I really encourage you to purchase it. I am not saying that because it's of any benefit to me other than you having the information you need for your coders and billers at your fingertips. And it's really important to remember that health plans are getting a file, a CPT data file every fall that they are just auto-integrating and uploading into their claims processing technology. And so knowing what those code descriptors are, what the numbers are, what the parentheticals under those codes are, is really, really important. And that can only be found in the electronic or the paper copy of the AMA's code book. So in addition to the code book, the AMA publishes articles on a monthly basis called CPT Assistant Articles. They contain essential information that allows a full understanding of the code set and how it should be reported. Again, all of this is copyrighted, so it can't be distributed by me or anyone else for free. You do have to pay for these items. I think individual articles are like $20. The code book is a little bit pricier, but again, it's really worth having if you're looking to work with health plans and bill health insurance using CPT codes. Your payers should comply with the guidance provided in those resources. So if they have policies that contradict them, having these resources in front of you when you're on the phone with customer service or whomever to be able to point out those discrepancies is really, really powerful and important to set yourself up for success. And your payers might not be referencing the correct materials. So if you can demonstrate that to them, they often will make adjustments to their policies. So again, set yourself up for success. Make sure you're playing from the same rule book as they are. So which services can I report? So this is per the CPT book. This is our code number, and you see the little plus here. That means that it's an add-on code. It's so 0770T, virtual reality technology to assist therapy. Lists separately in addition to the code for primary procedure. So we talked about a sunset date. Right now, that will be January 2028 if action isn't taken before then to elevate the code. And then here's our parenthetical. These are really important. You can't just rely on those code descriptors. You need to make sure that you're reading parentheticals. So for instance, this parenthetical tells us all of these therapies that this code can be appended to. And you can see down at the bottom that we've got psychotherapy, OT, PT, speech, health and behavioral interventions, and adaptive behavior services code sets. Again, important here in orange to be highlighted, a parenthetical telling us we shouldn't report the add-on code more than once per session. So it's primary procedure and whatever service or therapy that is, and then your add-on code below it on your claim form. So if you have questions, we want to know. So I have given several ways to easily reach me, and depending on which therapies your practice, and maybe your practice provides a whole bunch of these services, which is wonderful, recommendations on how to stay up to date. So if you are doing speech, OT, PT, psychotherapy, go to the specialty societies websites. They have great coding and reimbursement resources, often for free. So you've got the acronyms of those groups there. I also, as Denise mentioned, am the CPT consultant to the ABA Coding Coalition that developed and then elevated the ABA codes to Category 1 status. So I've got our website there. On the main screen, you can ask any question you want, and it comes right to me. So that's one option to get to me if you have questions about this code and reporting Floreo with one of these therapeutic services, or you can just reach out directly, and my email is there for you to use. So some important terms and concepts that I want to make sure folks understand if you are already using this code or considering it. Concurrent billing and add-on codes. So these are frequent hot topics, especially concurrent billing with some of the code sets that we've talked about. So what does this concurrent word mean? Many think that means services delivered to one patient or client on the same day. So maybe we have ABA and speech on the same date of service. That is actually not what concurrent means. Concurrent means billed at overlapping times. So with an add-on code, we will always be billing things concurrently because you can't bill this T code 0770T by itself. It can't be on a claim form alone for a period of time. It needs to have that primary procedure. That's literally the point of structuring something as an add-on code, is it added to something billed concurrently. Now, perhaps if you have hour-and-a-half speech session, perhaps you're only using Floreo for a portion of that session. That's where your times come into play, and you need to be really careful in your documentation to delineate what portion of the time was Floreo being used for the session, what portion was it not, so on and so forth. So it also is a practice expense only code. And so what does this mean? In addition to being an add-on code, we're talking about PE only here. So I'll talk in a minute about reimbursement and how the code is currently structured. But when a code is designated in the code book, and that's by a little icon that you'll see there, that it's a PE only code or practice expense only, it means that there is not any physician or qualified healthcare professional work involved in its use separate from or in addition to your base therapy service. So the valuation, as you're thinking about what is the time and resource, what are the time and resources dedicated to using this 0770T virtual reality add-on code, we should only be thinking about any extra separate time that your staff are spending. So for these services, that would probably be a technician or a nurse, an RBT, an LPN, an OT or PT assistant, etc. As well as what supplies and what equipment are being used specific to the technology. So the code is currently carrier priced. That means that individual payers negotiate rates for services directly with providers. There's no set reimbursement rate. They may not have any set reimbursement rate in their fee schedule if they're covering the code already. And so it's up to you on your claims to determine what you think the appropriate, reasonable, and customary fee for using this add-on code should be. Important to know, we're not here today, but just to know what the alternative to carrier pricing is and have a little bit of an understanding about that would be if codes have gone through the valuation process through the American Medical Association to establish what we call relative value units or RVUs. Medicare uses a physician fee schedule to determine payments for over, and I think probably we're at about 10,000 codes now. The fee for each service depends on its assigned RVUs, which rank on a common scale the resources used to provide each service. So those resources are the physician work, the practice expense, which we just talked about, and the professional liability insurance, all rolled up into one. So there'd be RVUs for each of those buckets, summed together. And then every year in the physician fee schedule, CMS, Center for Medicare and Medicaid Services, proposes a conversion factor that you times RVUs by to get your resulting reimbursement rate. When services or codes have gone through the valuation process and have assigned RVUs, private health plans, commercial health plans often mirror those rates or use them as a guidepost to develop their own fee schedule rates. And so that's why it's pretty important to just have a general understanding of what, having gone through the AMA CMS valuation process, means in contrast to being carrier priced, which again, our codes are currently carrier priced. However, the base therapy codes that this code can be used with, many of those are not and do have assigned valuation rates by CMS. So just important to think about. So how in the world, if I'm just supposed to come up with a rate for this code to start reporting it with some of these services, how do I go about doing that? So the first thing that I always say, and if you've heard me speak before, you've heard me beat this drum, but it's always really, really, really important to respect our antitrust laws, which means that we can't sit around and talk about what Aetna and Blue Cross Blue Shield and TRICARE pay us for a given service. Your charges are specific to your practice, and you shouldn't discuss those with other providers in order to avoid any appearance of price fixing or other things that are prohibited under the Stark antitrust laws. But we can give you some guides to how you should think about deciding what's the right price for your practice. So you should consider your direct and indirect costs, again, specific to Floreo. You shouldn't double count items that you need for the therapy session because you're already being paid for those through the reimbursement that you receive for the therapy service itself.
So Jenna, can I ask you a couple of like suggested items and see what you think about it?
Sure.
So let's say a staff member has to spend an extra hour doing Floreo training to understand how to use it. Is that extra hour of staff time something they can consider as a practice expense?
Unfortunately, no. So that would be an indirect cost to staff training for all of these services would be considered bundled because it's not a face-to-face activity with your client. And so it's sort of built into the resulting use of the technology rather than a billable event.
Okay. And what about, let's say that Floreo is delivered often in a swivel chair so that the person can move around. And let's say you don't have one in your office, so you want to go out and buy a new swivel chair. Could that be included?
It can, and so that would fall into our little yellow or golden line here. That would be a piece of equipment because it's reusable. Presumably you can use that swivel chair for many sessions, many clients. And in thinking about items like that, we need to think about what is their typical useful life and sort of amortize that cost across how long we think it will last and how many sessions we think we will be able to provide during its useful life. So a little bit of math there on the equipment as compared to the bucket above, which is supplies. So these are things we throw away or it can only be used once. So one per session or however many. So like cleaning wipes for the device and the headset were things we had talked about at one point in time. I don't know, Kleenex are food items, straws, disposable silverware, all things like that that are disposable. Paper would be something if you're taking paper data relative to Floreo specifically that you might consider in that bucket.
And so then if you had to go out and buy an iPad because you didn't have one in the office, that would also be something that you could incorporate into the expense.
Absolutely. And again, we'd be doing that same math problem as the swivel chair. We'd want to think about, in my practice, an iPad typically lasts me, if I'm lucky, 6 to 12 months. I guess it depends on what the service is you're most commonly pairing Floreo with. But in some situations, I know technology may get chucked across the room on occasion, might have a short use life. And so just keep thinking about your typical scenario at your practice. Maybe in a psychotherapy model, an iPad lasts 2 years. And so you want to think about that and divide it by how many sessions, again, you would most commonly deliver during that time frame to get a per.
Okay, so this is a hard one. How about if someone is doing teletherapy and they have a subscription to Zoom so they could do a video call with their patient who is at home using Floreo? Can they use the Zoom subscription as part of the practice expense?
Probably not, because I think that's embedded in your primary procedure. You're already using it you would be using it, I would envision, regardless for the base procedure. And again, most of the services in this that Floreo can be paired with, or this T code can be paired with, other than the ABA codes, I believe, have been through the valuation process. So the reimbursement rate that's assigned to those services would already be envisioned to be capturing that.
Very good. Thank you so much.
Yeah, you bet. I think the hardest one, at least for me to wrap my brain around, is the extra staff time. And so I think really breaking down, if I wasn't using this technology during whatever therapeutic session I'm utilizing it for, how much staff time would have been spent. I'm thinking, and Denise, you certainly know better than I do, so chime in here, that we're really just looking here for setup and then conclusion time for the staff, because we don't want to overlay the time that or if the session wouldn't have used a staff, but now I need one because Floreo requires it, and then there's another provider rendering the base service, that then the whole time would be counted for utilization. But I just sort of thinking about making sure it's really dedicated to the use of the technology, not double dipping, so to speak, for the therapeutic procedure.
Yeah, that makes sense.
All right. Other important terms and concepts are rounding rules. So it's important to note that with time-based CPT codes, a service may be reported when half the time increment of that code descriptor has been met. All of the codes that this T code can be paired with are time-based codes, but they are very different time increments. So really, again, have the code book, educate yourself, know what your rounding rule threshold is for that particular service, because it could be anywhere from having to do 8 minutes of something to having to do 45 minutes of something in order to be able to report a unit of the base therapeutic service. So really pay attention to that. And again, be mindful when you're pairing your T code for the virtual reality. So payer implementation, just a little bit about what we're doing. We are moving and grooving, trying to get the word out. And I love hearing Denise say at the beginning that she feels like we're reaching a new height with awareness about Floreo specifically. That's wonderful. I agree. And we're going to keep pushing. So in March of 2023, we sent a letter introducing the code and Floreo's technology specifically to over 100 health plans, which included Medicaid and commercial health plans. We have heard back from a handful of those plans on whether or not they're interested in covering, and have had some really nice discussions already with them about integrating the code into their fee schedules. In May, so last month, we sent letters to over 200 contacts at Wisconsin Medicaid agencies, encouraging them to implement the code into their respective programs. And we are currently, my team is working very hard on researching states in the order of priority that, for various reasons, that Floreo has directed us. So our next bundle will be going out this week of several hundred letters to Tennessee Medicaid agencies. After that, we are focused on New York and then California. So I anticipate every month, hopefully, that we'll be getting out new batches of letters and hearing back from them with questions or opening the door to meetings or educational sessions and all of those good things. In terms of payer implementation, payers already have access to this code in their 2023 code set file from CMS. So if you have a health plan telling you they have no way to implement the code, that's not true. It's in their upload file. They may not be aware of it, but it's in there. They may be reluctant to make mid-year changes. I see that a lot with commercial health plans. It's kind of a pain in the neck for them. So if that's the first feedback you get, don't give up. Encourage them to do so at a minimum by January 2024. You need to make sure you're ready, though, if health plans say yes to you. So make sure that if you're using an electronic medical record, that you've reached out to your contract contact and asked them to ensure 0770T is available to you in their electronic medical system. And then please communicate with us. It's so helpful to know what your health plans are saying to you if you are individually reaching out. Lots of times you guys have great relationships already built up with your health plans that you're contracted with. So let's utilize those relationships. Go ahead and ask. And I'm going to show you some sort of canned questions to ask if you're approaching payers here in a minute. But let us know what their responses are. Let us know if people are covering the code. We have trackers going. We're trying to watch implementation trends. I have this beautiful vision in my brain of like the map turning green as we slowly start to get the word out. So yes, please contact us and let us know.
So let me just say here, like, we have customers who are getting coverage for this, and they've approached their payers, and the payers would at first say no. We've had one customer who the payer said, no, Floreo is not evidence-based. And they went ahead and they showed internal data. So one thing you can do is start tracking among yourselves about how your clients are doing. If you can show a client that is not using Floreo and compare it to a client who does use Floreo, and you see that they're improving quicker, that's great evidence to show your payers, and they will look at it and change their mind. So this one particular client, the payer changed their mind based on the internal data they showed, and they covered Floreo. So don't, I would say reach out and ask. It doesn't hurt to ask. And if you can keep your internal records about how Floreo is doing in your practice, it certainly will help.
Yeah, that's a great point. I mean, always with anything that you're asking for prior authorization for, or, asking to amend and add a code in this instance to an existing authorization, you have to be able to demonstrate medical necessity for that specific individual. And having literature available, which I'm sure Denise and her team would be happy to help point you to in terms of what they've already got out there for the medical device approval process. be ready, be prepared. There's a lot of powerful data and information already out there that you can use to try to educate and encourage them to maybe open their minds a little bit. So here's our little list of suggested questions to use when approaching a payer, either in follow-up or for the first time. Will you be reimbursing for or covering Floreo using the new code? If yes, what's the time frame that you're envisioning on implementation? If no, how would you guide providers to report the use of Floreo technology for claims processing and reimbursement? Obviously, bullet 3 isn't where we want to be. We want consistent coverage and reimbursement for the service, but we also want people to be using Floreo. So if they shut the door on the code initially or pretty firmly, I think it's still important to ask them, well, we have this great evidence-based technology. How would you envision then covering something that's medically necessary for my clients? Ask them if they're adding the code to their fee schedule, when will the updated fee schedule be published, and what rate of reimbursement might they assign to the code? And then always remember to ask about prior auth. Just because they may not require prior authorization for the therapeutic services, they might require it for the T code. So don't just assume that they're going to handle it the way they handle other things. Ask the specific question and what that process looks like. Why is it important to use this code? So I just mentioned it's not ideal if we're all sort of doing our own thing to get Floreo reimbursed. And I think it's a pretty common question as to why. Consistency in reporting the use of any virtual reality technology with therapies is going to be important. Again, Denise mentioned this was intentionally created to be a broad code. It's foreseeable that other VR tools may come to the market at some point that would fit within the definition of this code. So it will avoid, if and when that happens, confusion by payers and providers on how to report those kinds of technologies and their time and cost in doing so. It also makes it easier for providers if there's only one way to report things versus this plan covers it this way and that plan does this and this plan doesn't cover it at all. And so it really will help to make things more consistent and avoid error in claims processing for your practices. Momentum with payers. Piecemeal contracts and coverage really results ultimately in erratic coverage and really inconsistent reimbursement rates. So it does benefit the greater good to have a more stable reimbursement climate where a code is consistently used and we're gathering data and seeing the benefits of that, and negotiated reimbursement rates, if it's carrier price code, which this is, are able to find some kind of a steady state among health plans and regions. And then, of course, I mentioned in the beginning, to get our Category 1 code, we have to demonstrate that widespread use. So if people aren't using this T code as tracking for us to be able to show that to the CPT panel, we will have a very hard time elevating this to a permanent code, which again will only benefit providers and improve coverage long term. So with that, I'll ask if either Heather or Denise have anything to add or anything I missed, and then I think we're going to take some questions.
I don't have anything to add, but Denise, go ahead if you do.
I was just going to say, Jenna, that was fantastic. Thank you so much.
Agreed.
You took something that's really complicated and made it very understandable, and I appreciate that for sure. I think our customers will too.
Absolutely. Yeah, thanks for saying that, Denise. We do have a couple of questions in the Q&A, so I'll just read them off. Is this specific to ABA only? Just a clarification question.
I appreciate the question because I didn't modify my slide. So I'm sorry, no, it's not. There's all sorts of therapies that this can be done with. And we're putting this up, right? So the list there will be available for folks so we've got at a basic level, PT, speech, OT, health and behavioral interventions, psychotherapy, and ABA. So lots of things to pick from there. And that's, again, get your CPT book, get it out, look at it. They're all there.
And we have another question too, but just want to encourage folks while we're still here, please do put your questions into that Q&A. We'll wait another few minutes if someone's frantically typing into that Q&A box. But another question right now, what if you were using a company like Central Reach? Do they have the code in their system?
So again, if you're using a larger EMR that I think many of us are familiar with, like Central Reach, you need to reach out to your contacts. it absolutely should be available, but you need to reach out to whoever your contract or your account rep is, send them a note and say, hey, I'm looking to use this new code that came out on January 1st. Can you make sure it's available for me in the system? And that should not be a difficult request.
And Jenna, my understanding, correct me if I'm wrong, is that you can put in your own codes. You don't, it might not be in a drop-down menu, but you can add your own. So you could put it in yourself in Central Reach as well as probably others.
It's true. You do need to make sure that it's recognized, like that it's built into the background of their software, because even if you hard enter it in, when you go to push that claim through their clearinghouse, it will get stuck if their software isn't also kind of speaking that language. For lack of a better, easier way to explain that, I am not an IT person, but but I know that it will just go nowhere essentially if you don't have them turn it on in the background.
Sounds like Floreo if you don't have your iPhone ready to go with your iPad. So we're very familiar. Another question that just came in, what states are currently accepting the code?
I think it's hard to say by state. We are aware of several large health plans that are covering the service. Denise, do you want to talk a little bit about some of the states you guys are already working with?
Yeah, so I understand that there are some plans in California that are covering it, and there might be a plan that's going to start covering it soon in Tennessee. Wisconsin Medicaid is allowing, not under this code, but they're covering it under a waiver program that they have. It's called CLTS. And we would encourage you, if you know, a lot of the states that we're already in, it all happened organically through our clients. So if you know that you think your state might be interested or you want to approach them, we would love to partner with you to approach the state to talk about it, because that's how it works. Like literally, that's how it happened in Wisconsin. We had a client who wanted it. They approached the person who arranged services for them and says, I want Floreo. They saw it. We showed them a demo. They said, oh, we want to take this to the state. The state stakeholders saw it. They liked it, and they figured out a way for us to fit into their structure. So that's how it works. And we're always here and happy to do presentations to payers or to state agencies or to school. So you just let us know how we can help you.
Yeah, absolutely. And, you know, I'm glad you brought up that point. Members, so the families that are covered under the health plans are your most powerful advocacy group. And so if you are having a hard time with the health plan, getting your parents, who are very savvy about this kind of thing in many cases, they've been around the block with trying to get coverage and access, and they've fought for the services and coverages they have. Remember that having them make the ask, in addition to you reaching out directly to your health plans or your contracted agencies, is equally important. If you're struggling, that can often be very powerful add.
And I would also add that a lot of plans are sponsored by employers. And so even though it might be Aetna, it's actually an employer who's paying Aetna to do it. And they're called self-funded plans. And so lots of times parents can get things covered under the special arrangements with the self-funded plan. So that's also an opportunity.
Yep.
So I don't see any other questions in the Q&A, but again, if someone is frantically typing, we'll give you another couple seconds. But Denise and Jenna, do you have any last thoughts that you want to share with the group today?
No, I think this was great. Thank you, Jenna, for your time and for this discussion. And I would say if anyone has any questions that we didn't address, please feel free to reach out to Floreo or to Jenna. We're here to support you, and just communicate with us your successes, or even when you're having trouble, so we can support you and assist you when you're trying to advocate with payers.
Absolutely agree. Don't be shy. We're here and we want to hear how it's going, good or bad or in the middle. And we're really excited about the momentum this is gaining, and frankly, the outcomes, the clinical outcomes that are being reported. So please reach out to us if you're a little shy today, and we look forward to hearing from you. Thanks again for having me.
Yeah, thanks again for joining us. And thank you everyone for coming and sharing your lunch break or your breakfast time with us. We really appreciate your interest, and we're looking forward to moving things forward with you. So thanks again. We'll be talking soon.
Thank you.
Bye-bye.